Good afternoon, everyone, and welcome to the Domestic Violence Advocacy Training. My name is Meg, and I will be helping run this webinar. Before we get started, please note that you'll be muted throughout the webinar. If you have any questions or comments, please type them in the chat box. This webinar will be recorded and distributed, and at the conclusion of today's event, please be sure to complete the evaluation that will be sent in the follow-up email. And without further ado, I'll pass it to Lindsay.
Hi, everyone. Good afternoon. Thank you so much for joining us. My name is Lindsay Weaver. I'm the Integrated Health Program Coordinator at the Ohio Association of Community Health Centers. This training is a little bit unusual for us because we are a membership organization for our state federally qualified health centers, and we have opened this up to non-members and community-based organizations for reaching survivors of domestic violence, human trafficking specifically. So we'll have a little bit of introduction later on who we are as OACHC, what a federally qualified health center is, how to connect. But I will first introduce our speakers. So first we have Anna Shelton. She is currently working on her Master's of Social Work through Eastern Kentucky University. She has been an advocate at Artemis Center in Dayton for 4 years and has been working with Rachel Ramirez for her practicum placement at the Ohio Domestic Violence Network for almost 1 year. We also have Abby Bowman. She is a student working on her Master's of Public Health at the Ohio State University. She has worked at Turning Point in Delaware for about 3 years, and she decided to do her summer internship with the Ohio Domestic Violence Network, working on projects related to partner-inflicted brain injury. So we are thrilled to have both of you on and to have so many great folks from all across the state. So I will go ahead and hand things off to Anna and Abby. And if you have not yet already, please introduce yourself in the chat.
Hi, everyone. So as Lindsay said, the goal of today's training is to provide DV advocacy staff with the tools and resources to help you address the health status and health needs of your clients, including offering information and referrals to community health centers, and then also now for COVID testing and vaccinations. So these slides were developed by Project Catalyst and the National Health Resource Center on Domestic Violence, a project of Futures Without Violence. The national data and research on intimate partner violence and human trafficking largely focuses on adolescents and adult women who are disproportionately impacted by violence and more often sustain injuries and fatality as compared to men. Therefore, many of our examples today are focused on adolescents and women, but as we know, these also can happen with men as well. So as we've asked, if you would please just go ahead and type your name in the chat, and then I'll go on and just kind of walk us through Zoom. So like Lindsay said, you can listen either through your phone or through the computer speaker audio, and then everyone is muted, but if you want to unmute, you're welcome to, and you can also use the chat box if you have any questions. So about the team, Lindsay kind of gave us an overview. The other people on the team are Kathy Marcus, Juliana Nemeth, Rachel Ramirez, who I do not believe is on the call, and then Deborah Seltzer, Dana, and then as we just met, Lindsay. And so this project is supported by the USDHS. So these are your federal dollars that work and reflect the innovations to take care of our most marginalized groups among us. So we have 2 agencies from the federal level committed to doing this work and breaking down the silos to new solutions. And so this is just an example of those federal dollars at work. And then, so Project Catalyst is a multi-year federal initiative. This is the 3rd cycle of funding to strengthen the cross-sector collaboration between state domestic violence coalitions, primary care associations, and departments on health or public health. So these multidisciplinary teams offer training and technical assistance directly to health centers and DV programs across the state, and will do so even more later this spring. So our goal is to improve the health and safety of survivors of intimate partner violence and human trafficking, as well to promote prevention. So this photo on the right is from a meeting back before COVID, when everyone was able to get together before the pandemic. So this next slide is about the collaborative working with HRSA and the FVPSA. This began in 2015 by piloting approaches with health centers and DV programs at the local level. So we can see on this slide that those 10 pilot sites lifted out in the text boxes around the map. Following in 2017, these models and lessons learned were scaled up to produce the development of project catalysts for state and tertiary-wide cross-sector collaborations. Futures first worked with the states in the map in green, who received $75,000 to take part. Those were Alaska, Idaho, Connecticut, and Iowa, including participants from Minnesota. And then the second phase included those states in the purple, which are Colorado, North Carolina, and the tertiaries of Guam and other Pacific islands. And now we're in our final phase. And so we're working with Ohio, Minnesota, and Georgia, which are in the blue. So through these partnerships, we have seen gains in sustainable systematic changes, leadership development, and increased practice changes within health centers and DV programs that are likely to improve the health outcomes for our survivors. And then this is just a map of our DV programs. And like we said, these slides will get sent out. So anyone that wants access to these will have that. So just a little bit more housekeeping before we get started. Our schedule today, this is a little bit off. We're going to be together from 1:30 to 4:30, and then we will take about a 10-minute break in the middle. And then if you need to color or whatever you need to do to take care of yourself, you're welcome to do that. And so we just want to keep in mind that what we say here stays here. So if anyone does need to talk about any examples of clients, just don't provide their names or offer any details that would identify who you're specifically talking about. You know, we want everyone to feel safe and comfortable throughout the training. So if you do have to leave the room or take unscheduled breaks, you're welcome to do that. Or you can drop in the chat box if you have any questions. And then also we know that there may be people on the call who are survivors of domestic violence or sexual violence. And so these things that we're going to be talking about could potentially be painful memories. So just being able to feel safe, and if you need to process, you're welcome to do that with any of the panelists on the call. So today's agenda, we have 5 different sections for the training. So first, we'll be discussing self-care and organizational strategies for community health centers to promote trauma-informed workplaces. And then we'll move on towards providing healing-centered workplaces, and just go through the rest of those sections. So as we move in to the first module, we're going to talk about the benefits of community health centers and advocacy. So as we know, 17% of abused women reported that a partner prevented them from accessing healthcare, compared to 2% of non-abused women. So these statistics just reinforce how important it is to address the health needs when clients enter domestic violence programs. It could be the first time in a really long time that a survivor's had access to any kind of health services. So DV programs are really in a unique position to help intervene and help reduce the health consequences related to clients that are experiencing violence and abuse. So as you already know, if you're on this call, intimate partner violence has serious health impacts in both morbidity, related illnesses and injuries, and also death. So advocates, we're in a unique position to intervene and reduce health consequences related to experiencing violence. Many survivors haven't been able to receive care in a long time or are primarily concerned about their children's care. But we all know that healthcare is an important part of survivors' healing. And when health needs are being addressed, survivors can be more present and engaged in advocacy services. Advocates are in a unique position to intervene, and they can partner with community health centers and other public programs, such as health departments, hospitals, clinics, to provide additional education and resources. We know the criminal justice system is not always a primary resource for clients, so health referrals may be more impactful. Advocates also focus on the whole person and not just the crisis and experiencing violence. And so, in these times of COVID-19, health centers and public health can help advocates and clients get COVID testing, health education, and vaccine, but they can also help address burnout among advocates. So I'm going to pass it back over to Lindsay for just a couple of minutes for her to discuss what a community health center is.
Awesome. Thank you so much, Anna. So community health centers are community-based, patient-directed organizations. They deliver comprehensive, culturally competent, high-quality primary care health services. And when we talk about primary care, we're not just talking about traditional medical services, but ideally the full scope of what primary care is, which includes dental. Some health centers offer vision, behavioral health, substance use disorder. So really seeing care for the whole person. OHCHD is the largest primary care network in Ohio and actually in the whole country. These data might be a little bit outdated, but in 2019, we have provided comprehensive care to 1 in 14 Ohioans and 1 in 7 Medicaid beneficiaries in the state. And we have community health centers in 72 of Ohio's 88 counties. And the mission is cut off a little bit, so I do apologize. But generally, the mission of a federally qualified health center is to provide accessible, competent, culturally competent care in the full scope of primary care health services to medically underserved communities and vulnerable populations. Next slide, please. So we have 57 federally qualified health centers, or rather community health center organizations in the state. Again, this might be a little bit outdated, but as of 2019, we had 425 plus locations statewide. So for among the 57 organizations, they could have numerous locations. 67 of those multiple locations were school-based health centers, and 95 included dental sites. Some other statistics from 2019 data, healthcare, home, and family doctors for over 850,000 Ohioans annually, and there were 3.5 million patient visits seen at federally qualified health centers. Next slide, please. So these are just some demographics about the patient populations that we serve. These are a little bit difficult to see, I apologize, but the gist of this is we do see a number of, as far as demographics, we see a number of folks varying ages. I believe, Tiffany, correct me if I'm wrong, it's mostly between 25 and 64, and then another good portion 65 plus. Over half of our patient population do receive our Medicaid beneficiaries, and then the majority of patients who are seen at a federally qualified health center are below at least the 100% poverty level. So again, if folks are interested, we can have more clear depictions of these statistics, but this is just to give you a broad idea of the patient populations that we serve at our federally qualified health centers. Next slide. And we wanted to include this map here. So we are coming from a number of communities here. I see Toledo, I see St. Clairsville, I see, Lorain County. So we don't have, I can share this out again, but this is just to give you all an idea of where federally qualified health centers are, and we're all over the place. So really the goal of this project from here, was to build those partnerships, to fill those gaps that we see among our survivors, whether they're clients through a DV program or patients at a federally qualified health center, and to reach those gaps within our community. So I think that's all I have. Next slide. Oh, pardon. Again, giving a full scope of the types of providers and types of visits that we have. I won't go into it in depth, but as you can see, we under the guidance of care for the whole person and the full scope of primary care, we have a number of providers and full scopes of visits. Next slide, please. And I should also clarify that we have a number of enabling services to help patients access care, including translation services, transportation, et cetera. Also, a big priority for OACHC is expanding MAT and SUD treatment, particularly with the expansion of Medicaid. Health centers' ability to reach more behavioral health and SUD patients, including opioid use disorder, has dramatically increased. So most of our health centers have integrated medicated assistance treatment into their primary care practices, and that has increased significantly since 2013. So this has been great as an opportunity for best practice modeling, for primary care integration. It's been more accessible to patients. It's effective and efficient, and also making this readily available has helped to reduce stigma within the community. I've also included is 340B, which I won't bore you all to tears about what 340B is, but it is basically a program that allows federally qualified health centers to prescribe medications at lower cost. So if you come out of this training worried about how to make sure that your clients are getting their prescriptions, do think of this in mind about how federally qualified health centers can reduce that barrier. Next slide. So we have some contact information. If you have more medical related questions, I recommend that you reach out to Dr. Dana Blanchard, our Chief Medical Officer, or you can email me for any other immediate questions. But I will hand it over to Anna.
Thanks, Lindsay. So that was an overview of community health centers. Just a couple of other additional points about community health centers is that they also provide supportive services such as health education, translation, and transportation that can promote access to healthcare. So they develop systems of patient-centered and integrated care that can respond to the unique needs of diverse medically underserved areas and populations. Some also focus on special populations, including those experiencing homelessness, migratory and seasonal agricultural workers, and residents of public housing. Lastly, they operate under the direction and patient majority governing boards of autonomous community-based organizations, which include private and nonprofit organizations and faith-based organizations. So to give context for how many people are served and how long they have been served in the range of services provided, HRSA's investments have advanced the nation's health by ensuring more patients and communities each year have access to high quality comprehensive primary care. Today, HRSA's funds nearly 1,400 health centers operating almost 13,000 services delivery sites in every U.S. state, U.S. territory, and the District of Columbia. So health centers have providers and staff serving nearly 30 million patients. So that's 1 in 11 patients in the country. And health centers have more than tripled the number of patients served since 2000. So one of the many reasons that health centers are such an important resource for survivors is because they have health enrollment specialists. So oftentimes survivors may not have access to healthcare coverage, or they may experience an interruption in coverage due to the abuse. So ensuring that survivors are able to establish a medical home is crucial in offering long-term support and continuous care for survivors. In addition, facilitating warm referrals with the health centers. So we encourage DV advocacy programs to ask their clients about their health needs and whether or not they have health insurance. And then if not, then advocates can share information about health enrollment specialists, which is really great for survivors when they're leaving their abusers. So one really important point for survivor healthcare is that being a survivor of domestic violence actually qualifies the survivor to be eligible to enroll in healthcare anytime through the year. So this means that they don't have to wait for open enrollment like other people would if they were needing health insurance. Future's website has an archived webinar, an advocate memo, and other resources about how that open enrollment works. Even if a client is healthy with no obvious illness or injuries or acute health needs, it's important to help establish a connection with them to a primary care provider now and establish a medical home where they can go to access routine checkups, or where they can go if they do get sick, or if they need any services for their children. So if you're able to establish this in advance, it can help people avoid unnecessary and costly expenses related to emergency room visits, which often fall back for people who have not yet established a relationship with a primary care provider or medical home. So we've kind of talked about what a health center can offer. We also want to emphasize how important formalizing partnerships between health centers and your local DV program can be. It can be instrumental to help provide support to the survivor and help promote safety in a coordinated way. That's really what the heart of Project Catalyst is. We want health centers and DV advocacy programs to have shared health and safety goals, since we're both serving clients and with the increased risk of COVID. So for example, those living in close quarters with others, people experiencing homelessness, elders, and people with chronic health issues, and those who are immune and compromised. So here is what we've been hearing from different advocacy programs about the benefits of partnering with a community health center during COVID. Advocacy programs have been able to consult with health center staff on guidance for shelter-in-place protocols, guidance for shelters, and how to support staff who are ill. Health centers have also been really helpful in enrolling clients and staff in health insurance. And because community health centers offer enabling services such as transportation and interpretation, this is really helpful for clients from advocacy programs. They also have providing COVID-19 testing either through drive-through or walk-up, and vaccinations, and can also provide access to prescriptions and medication refills. So this just shows some of the benefits and support health centers can provide to DV programs for both clients and staff. And then, as we, the people who do this DV work, know, we can be lifelines for survivors and are crucial in supporting survivors for both their health and promoting access to health services. So we want to be able to be the first responders for people experiencing intimate partner violence and human trafficking. And we want to be an accessible resource for both clients and their children to access their health needs and healthcare. And we also want to be an access point to information on health centers and how to get COVID-19 testing or vaccines and other reproductive and prenatal care, HIV care. So we can move on unless anyone has any questions or thoughts on anything that we've talked about. I'll give it a few seconds for folks to drop anything in the chat, or if anyone has any questions about how a health center could help you in your agency, please feel free to drop that in the chat. I'm not seeing anything, so I will be passing it over to Abby for the next module. And so I will just stop sharing my screen. Oh, Caitlin said, is open enrollment for DV survivors contingent and being connected to a health center? Lindsay, would you mind answering that?
Sorry about that.
There you go.
I am not a Medicaid specialist, so we're gonna have to investigate internally on that.
If they do present to a health center, though, this is Tiffany, a patient can get presumptive eligibility through Medicaid to be treated that day. Health centers specialize in this, whether it's open enrollment for insurance or not. So they will not be precluded from being seen for care that day.
No. And then to clarify again, for survivors of domestic violence, you don't have to worry about enrolling in the open enrollment period because surviving domestic violence is a special qualifying event. So again, your health center will be able to help your patients out with that.
Thank you.
That's true for human trafficking also.
Sure.
I'm not sure about that. I do apologize. We can do a little bit of digging, but yeah, we can do some digging on that.
Those were great questions. Thank you all. Anyone else before I'm moving on? I'm doing module 2. Sorry, you're stuck with this voice for a few more slides. So we are going to move on to working with clients who experience trauma can affect us as advocates, leading to vicarious trauma and secondary trauma and traumatic stress. So the next section is reviewing different self-care strategies for professionals and health systems to promote healing-centered workplaces. So we're just gonna go ahead and type in the chat box a word or two that sums up how we're feeling today and kind of gauge where the room is. So if folks wouldn't mind just dropping in the chat how they're feeling. Hopeful, thanks. Frustrated, stressed, exhausted, yeah. And it's only Tuesday, I think. Tired, good. Tired, glad to be here. Content, stressed, very busy. Those always go together. Encouraged, content. Thank you all for sharing. So please feel free to keep dropping how you're feeling into the chat. I think sometimes just saying it out can help a little bit. So this is an additional list of what folks on the webinar may be thinking or experiencing. The last 2 points are acknowledging the very painful issues that we're also facing. So the stress in the world right now is deep, and we just want to take the time today to talk about what we can do to support each other during this time. And so to move us kind of past these somewhat negative or positive feelings, we'll just take a moment to read this quote by Maya Angelou. She said, "Here on the pulse of this new day, you may have the grace to look up and out and into your sister's eyes, into your brother's face, your country, and simply say, very simply, with hope, good morning." So As we move on, we're going to talk more about the impact of this work on advocates. So part of the reason this healing-centered focus matters is that we know there are higher levels of trauma among advocates and system level recommendations that can help counter that stress. So both needs to be addressed to create meaningful changes that center our work around wholeness and wellness. So it's not just for our clients, but it's for us as well. So in a study in 2019 of 142 victim advocates, 39.81% experienced secondary traumatic stress. And the study found that the only significant predictor of secondary traumatic stress was the number of direct hours spent providing this victim with services. So the study is suggesting that organizations should be mindful of the numbers of hours that the victim advocates work directly with the victim every day. And I feel like any advocates on this call were like, I don't need a study to tell me that. So when thinking about vicarious trauma, David Berceli's definition talks about how your worldview changes as a result of the stories that we hear. So this is a story from a prenatal case manager in Michigan who shared a story of a vicarious trauma at a training similar to one like this today. And she shared that her experience when working with a 14-year-old client and how it affected her. So she was supporting this young woman with her pregnancy, which was a result of a rape by a family member. And she worked with this woman around both her health, her trauma, and navigating the dysfunction in her family. And as she began to tell the story to the audience, her voice began to crack. And she said that she herself had a 14-year-old niece and that she just can't turn it off, meaning that she's constantly scanning the room when she's with her niece to see if anyone's looking at her the wrong way or see if she's perceiving anyone as a threat. So the worldview of her safety has changed from hearing her client's story. So the ways in which these stories get woven into our fabric is something that we need to take seriously and recognize that they have an impact. And then even thinking more about how COVID is having a bigger impact on us in the way of burnout, even more so now with the other barriers that we and our clients are facing. So we just need to be thinking structurally about how to create systems of change that can support advocates in meaningful ways. So we ask you to ask yourself, these questions to check in about burnout. Do I intuitively know, even if I'm not ready to say out loud, that my work is starting to impact my health, life, or relationship? And then the second question is, do I work harder than is healthy for my mind and body because the issue feels so deeply personal to me? So if we want to just take a minute and consider these two questions for ourselves, these questions we want you to sit and think about, and we know that a lot of people on the call probably say yes to both. And so this really just lends itself to the concept of trauma-informed care. And if anyone wants to comment on those, feel free to drop it in the box. So many of us on this call have probably heard about trauma-informed care. For those who haven't, I'll do just a quick overview of what trauma-informed care is. Trauma-informed care is the framework of moving from what's wrong with you to what happened to you. So it's a different way of holding people's experiences of trauma. And it's one of the things that allows folks to feel safer as they're working with us through their trauma. And it can help support them in the space that they need when we're trying to help them look at these situations. So this on the slide is from SAMHSA's Substance Abuse Administration website. And the link is there at the bottom if you're interested in learning more about trauma-informed care. But what patients are looking for with us with seeking services with a provider is safety and trustworthiness and a sense of peer support and collaboration with us. And we want to be able to listen and care about the choices in what our clients are saying. And so we need to look at this issue as part of the parcel of the fabric of the feeling you get when you walk into a space, or the feeling you get when you think about the provider walking into the room. So some of those things include what's on the screen, which is that safety, trustworthiness, peer support, collaboration, empowerment, and then acknowledging cultural, historical, and gender issues. And so we want to build on that trauma-informed care approach, but focus on something more whole. So if we think a little bit about the differences between trauma-informed care healing versus healing-centered engagement, which will give you the definition for healing-centered engagement in just a minute. Trauma-informed care is important, but it's not complete. It doesn't acknowledge the traumas experienced collectively. And as we've talked about with COVID and our experiences with understanding systematic racism and thinking about how to move forward. Our experiences with political polarization, all of these things are not just individual experiences. And so trauma-informed care doesn't really address the root causes. It focuses on coping with the symptoms rather than healing from them. And we want healing. So healing-centered engagement is building on that trauma-informed care. So this is complementing the trauma-informed systems change to include a new concept, taking it to the next level of healing-centered engagement. So what makes a difference is how we use language to promote the best of the best, not accept that a trauma-informed approach is enough. We want wholeness, wellness, systems of change that not only impact providers, but also impact patients as well. So this new concept called healing-centered engagement is important for clients as well as staff, and a responsibility to healthcare systems to build in healthy and supports and healing and supports for their staff. It's a structural climate issue that can be solved. So basically it supports providers with their own healing. This framework asks systems to build structures that address the realities facing staff. I'm not sure how many of you on this call today feel like your system is doing a really great job of taking care of you and your colleagues. If that's happening, wonderful. For those of you who perhaps you're thinking, wow, nobody's actually stopped to pay attention to me and what I need, I'm hoping that some of the administrators and folks that have the ability to make change are listening. We really want to build and need to build structures to better support patients and be present. Healing's a process that we all need, not just our survivors. And so as we go on and talk about that concept of self-care that's thrown around in all these different ways, when we talk about self-care, we're not talking about self-care light, such as like a manicure, pedicure, massage, or shopping, but rather it's pointing out something more profound. Self-care is about how to calm our nervous system when we're stressed. So as Audre Lorde said, caring for myself is not self-indulgence, it is self-preservation and an act of political welfare. Meaning we must fight to have this for ourselves and to be good and healthy within our own lives and be able to continue to support our families without burning out. During this time that we're shifting from Zoom and COVID, we're working differently and harder than ever before. And so carving out the time to recognize this is essential to address burnout. We really just need to take a second to stop and think what we're doing to address this self-care right now. And so our hope today after the training is that you consider continuing to have these conversations with staff and others in your agency to promote healing and care within your agencies, because we know it's critical for advocates. The link in this slide goes to a series of Zoom trainings about self-care and healing in the midst of the pandemic. So it's something that you could listen to as a group at a staff meeting or clinical meeting, and they're broken into sections. So you can just listen to 10 or 15 minutes as a group and then discuss. And so this is talking about self-compassion. So a few pointers on self-compassion is treating ourselves with the same kindness we would treat a friend with when things go wrong. accessing self-compassion, and then if your close friend was struggling with the same thing that you are, what would you tell them? And then focusing on how we can start turning those words that we would tell a friend towards ourselves. So we think this is a great framing to think about how we treat a friend. We should kind of start to treat ourselves like that. And then, so the key to reaping positive rewards comes from spending time alone, according to research out of Durham University. So despite the social stigma and apprehension about spending time alone, it's something that our bodies do crave. We might not know that we need the time alone to feel better, but we do. So what happens when we have the freedom to do nothing, no pressure to talk to anyone, or no obligation to make plans with people, may sound kind of strange, especially when many of us are coming out of this time of being isolated, but there's a different kind of time and space and benefits to spending some time alone. And so having time alone with your thoughts without distractions can be so important because it can help build confidence. It makes it easier for you to maintain boundaries, and especially when so much pain is coming at us. It can help boost our productivity and allow us to engage with others creatively. And while it's harder than it sounds, especially when working at home and having kids and pets and all these other responsibilities on top of our work, spending time alone can become maybe a ritual that you can make between, our Zoom calls or home responsibilities. So this is part of that like craving collective that can be really hard to do unless we do prioritize that for ourselves. And so one way to support reflective practice in the workplace is to have reflective supervision for all staff. This includes at all staffing levels. So our hope is that, especially during COVID and because of remote connections, that we can remedy sites that have not yet done this for all staff. So the definition of reflective supervision means stepping back from the immediate intense experience of hands-on work and taking the time to wonder what the staff experience really means. So what does that tell us about the client and about ourselves? Through this reflection, we can examine our thoughts and feelings about the experience and identify the intervention that best meets the family's goals and needs for self-sufficiency, growth, and self-development. And so we have these 4 steps for low impact debriefing, which include increased self-awareness, giving fair warning, asking consent, and limited disclosure. So the concept of low impact debriefing is that we're not dumping a massive amount of difficult information about our day or a client onto a coworker. We want to respect their boundaries and ask permission before we share. So to go a little bit deeper into these, increased self-awareness just means becoming aware of the stories that you tell and the level of detail. So what details do I need to share? So I know I'm guilty of like wanting to need support with one very specific thing with the client, but then I tell all the traumatic things, but the person I was telling it to didn't need to know all that. So just recognizing what details are pertinent to share in that situation, and then giving fair warning. So thinking about what you would say to someone if you were sharing bad news. So you better sit down, I need to tell you. I'm also guilty of not thinking of my coworkers like a normal human being and just like laying things on them without considering that it could be really impactful to them. And then asking consent before you talk to someone about something. So saying, I need to debrief with you is now a good time to do that. And then lastly, limiting disclosure. So starting with like the outer circle of the story, and as you're moving in, deciding how much of the graphic details you need to include. And then with that, checking in with yourself and asking, is this too much trauma information to share? And so we're going to do just a little activity And we can just, if you're comfortable typing it into the chat box, that would be great. But we're just going to do a quick exercise on reading our cues. If you're not comfortable, just feel free to jot it down on a piece of paper, make a mental note. But if you're willing to share, could you share some feelings that you feel when you're feeling regulated? So what your body's experiencing, what you're feeling, what your thoughts are like, and what you're doing when you're feeling balanced and regulated. And like I said, that could be in your body, feelings, thoughts, or behaviors. Active and energized, calm, peaceful, calm and regulated. I know for me, my neck doesn't hurt or my whole body feels not in pain if I'm feeling balanced and regulated. Content, positive. I feel neutral, not emotionally. Oh, I want to go back up to that. Not emotionally stormy and not caught up in the crisis. I think that is a great description. Someone shared that they've not felt regulated in months. They have brain fog, irritable. It's peaceful, less pain in the body, content when feeling regulated. Thank you. And then, so on the other side of that, how are people feeling when they're feeling dysregulated? So not feeling balanced, what are those experiences or thoughts or feelings like? Or focusing on maybe where you're feeling those tensions or aches. And if you're willing to type in the box and share, that would be wonderful. Someone said, I get headaches, irritable, extreme shoulder pain, headaches, dysregulated, tired, stressed, neck hurts. Yes. I also carry my stress in my neck. Headaches, nauseous, tightened muscles in the neck and shoulders, easily frustrated, more focused on negative versus strengths. Yes, that is incredibly relatable. Dysregulated is brain fog, distance, physical pain, anger, no appetite, headaches, and stomach aches. Thank you all for sharing. Someone shared, my thoughts are very negative, my boundaries suffer, I don't think so well before I speak. That I'm taking the words right out of my mouth. Thank you all for sharing. So we do this exercise because we don't often, I feel like, take time to think about how we're reacting or what our body's feeling when we're not in a good place. So when we do take this time, we can read ourselves faster and maybe catch ourselves when we start to feel dysregulated. So we can change our trajectory to get into a better place. So for everyone here, you may have heard a horrible story or lost a loved one, and like wondering, what do you do now? When you have to go see another client or work, another 7 hours. So figuring out what you can do to support yourself in how you're going to continue to move on your day is part of that mindful self-regulation. And so different mindful self-regulations include breathing, grounding, self-talk, and imagery. There are a range of things such as meditation, yoga movement, and music that can be used to help with self-regulation, as well as breathing. And so these are just some of the suggestions that have been given, and there are lots of different resources. I know people have suggested different apps for like guided meditations. So if anyone has any of those self-care ideas or self-care strategies that they use to mindful self-regulate, that would be great to drop in the chat. My brain is slipping right now on the app that I use for guided meditation, but if anyone wants to share. And then We will also have a list of resources here to help support staff. So these are resources that can help. Yes, Headspace and Calm. Thank you for sharing that with me. So these are different resources to help support staff. On this is actually a resource that if your workplace doesn't have a policy to help support staff that are experiencing intimate partner violence, you can visit Futures Workplaces Response to Domestic Violence and Sexual Violence Resource Center, which is listed on this slide, to help have tools that can help supervisors further support staff during COVID, or like I said, if staff members themselves are experiencing domestic violence. And then if you're interested in more examples of getting grounded in mindfulness and breathing, there are resources on here for that as well. And so that is it for me for now. I think we're going to take we can take an 11-minute break and come back at 2:30. And then we'll move on to the third module. Okay, see you all in about 10 minutes.
Welcome back, everyone, and we are going to move on to Module 3, which is titled Intimate Partner Violence, Human Trafficking, and Exploitation during COVID-19. So we're going to talk a little bit about we're going to move into a discussion about these definitions and the dynamics. Oops. So first, if you could go ahead and if you want to share in the chat box what you did on your break and if you were able to kind of disassociate for a few minutes and take a break, or you can also go ahead and start leaving some comments about what you think are some of the dynamics of intimate partner violence. Just made a smoothie. That's a fun one. Stretched and walked around. Me too. Took phone calls. That's not much of a break. Fed my cat, ate some lunch, did documenting, walked around. Nice. Checked in with staff. Got a snack. That's always a good break. Yeah, it sounds like at least most people got a little bit of a break during that. So what do we think are some of the dynamics of intimate partner violence then? So I guess some of them would be thinking of different components from the power and control wheel. So things like, I'm sorry, the question was, what do you think are some of the dynamics of intimate partner violence? Financial control, yeah, that's a big one. Isolation, yeah. Using fear or threats, absolutely. One person makes all the decisions, yes. And enforcement of power and control, yeah. Gaslighting and other forms of manipulation. Shaming and blaming, yeah, these are all great. Yeah, and like intimidation. Oh yeah, using immigration status against someone, that's a good one too. Yeah, you pretty much nailed all of them. The only other one that we kind of have big is like using intimidation. I think someone already mentioned coercion and threats. And similarly, like using immigration status, people will use children as a way to exert power and control. Yeah. So according to the National Intimate Partner and Sexual Violence Survey, 1 in 4 women and 1 in 9 men will experience intimate partner violence. So the highest percent of women impacted are ages 18 to 24, and many of them are mothers. The rates of IPV are also high among lesbian, gay, and bisexual communities, and the rates of physical and sexual violence are even higher for trans folks. So you can see on this slide that 34% of trans individuals reported lifetime physical abuse, and 64% reported experiences with sexual assault. And in rural settings, the rates can be as high as 1 in 2 for perinatal patients. So, and of course, we knew that we were going to see a spike in the rates of domestic violence during COVID-19, given the increased isolation and shelter-in-place policies happening nationally. This data is from the National Domestic Violence Hotline, which shows what the prevalence and experiences of IPV have looked like during COVID. This is survey data from March to May in 2020. And during this time, there was nearly a 10% increase in total contacts received at the hotline. And you can see the overall numbers of phone calls, online chats, and texts here on this slide. And about 90% of folks have experienced
emotional and verbal abuse, and 61% experienced physical abuse. And then economic and digital abuse have also been very common during the pandemic. So what are some of these survivor stories from COVID? Here are some stories from the National DV Hotline that were collected in that survey. So one survivor mentioned the abuser was using the virus as a scare tactic to keep the survivor away from their kids. Another caller mentioned that they could not file paperwork to remove the abuser from the home because all of the courts were closed. And we've heard a lot of survivors talk about the severity of their violence and how it's gotten worse during the isolation and shelter-in-place orders. And these are experiences that we've heard from advocates across the country as well. Immigrant survivors also experience some unique trolling behaviors, including threats of deportation, lying about immigration status, and withholding important documents. So we're going to move into a little bit more of a discussion about human trafficking and exploitation definitions. If you think you've provided care for someone who has been at risk for trafficking, currently being trafficked, or has a history of being trafficked, I just want you to kind of think about that now, because by the end of this training, I think almost everyone will realize that you've had an experience with someone who is or has been trafficked. So I'll have you respond to some of these questions in the chat box. So I just want you to think about, when you think about trafficking, how do you think that's showing up in your community? What words are your clients using to signal that trafficking or exploitation might be going on? And what about the intersectionality between intimate partner violence and human trafficking, and just kind of how you see these different things in your community and with the population that you work with? When clients talk about their partners making them do things they don't want to do, absolutely. The comment, my boyfriend has this friend. Yeah. And we're gonna talk some more about those intersections and vulnerable populations and how these intersect, but feel free to keep dropping things that you see in your communities. Oh, we've seen an increase in young people being approached by traffickers with the promise of making money during the pandemic. It's a big one. Associations with homelessness, addiction, and poverty, absolutely. Yeah. Awesome, thanks everyone. So we'll talk a little bit. Oh wait, sorry, there we go, okay. So we're gonna talk about some learning points and some things that you can think about when you're looking at trafficking and exploitation. So first, these are very common, and human trafficking and exploitation overlap a lot with domestic violence. People are vulnerable during COVID, like someone mentioned, with promises of making money. That's a great way to exert that exploitation of, hey, you need money, do this thing that I want you to do. And there have been a lot of job losses, and just a lot more exploitation has showed up as a result of it. So, and then with domestic violence, survivors don't always identify as being trafficked, and they really will rely on you as an advocate for support. So working with an advocate can be transformative in a client's understanding of their domestic violence, human trafficking experience, and how they heal. So in the year 2000, Congress passed legislation legally defining human trafficking through the Victims of Trafficking and Violence Protection Act. In this legislation, human trafficking is defined as a crime, and it established why types of trafficking crimes are able to be prosecuted under federal law. So what are the definitions under federal law? Labor trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for the purpose of involuntary servitude, peonage, debt bondage, or slavery. And B, it is important to note that the law only provides legal remedies for severe forms of sex trafficking, which is the recruitment, harboring, transportation, provision, or obtaining of a person for one, a commercial sex act through force, fraud, or coercion. Two, if the person is less than 18 years old and there is no requirement of force, fraud, or coercion. And it's important to note that the distinction that only victims experience severe forms of sex. So since the criminal definitions are very narrow in public health and healthcare, we look at a broader experience of the patients to see how exploitation can impact their health. So we'll turn a little bit more to exploitation. Labor exploitation in the broadest terms occurs when an employer is unfairly benefiting from their employees' work. So since fairness is subjective, many people may have different definitions of what constitutes exploitation. Labor exploitation is not a legal term. In fact, not all forms of labor exploitation are illegal. Labor violations, however, is a legal term, and it's used when employers violate federal, state, or municipal laws related to worker treatment, workplace safety, or record-keeping requirements. So labor violations could include paying wages below the required minimum wage, non-payment of overtime wages, illegal deductions from workers' pay, and the misclassification of workers for tax purposes. So, however, overlapping legislation excludes workers in certain industries, so not everyone is entitled to the same standards or protections. And then sexual exploitation is defined as actual or attempted abuse of a position of vulnerability, power, or trust for sexual purposes, including but not limited to profiting monetarily, socially, or politically. So this can include coercion from employers or the workplace, coercive rent or debt exchange, or trading drugs or sex. So this definition is really broad, and it highlights a lot of people who are vulnerable to this type of exploitation. So before we move on to the next slide, I just want to see what populations you think are the most vulnerable to sexual exploitation. Or even just the populations that you think are the most vulnerable in your community to types of violence, trafficking, and exploitation in general. Teenage girls, absolutely. Young people with limited resources who are neglected at home, absolutely. Homeless, lower socioeconomic status, and runaways, yes. Homeless young girls and boys. Yeah, the homeless population is a big group that are vulnerable to this. Developmentally disabled, LGBT youth, yes. Yeah. You guys have hit most of them. So yeah, as you mentioned, runaway and homeless youth, unsheltered, LGBT, and then also rural agricultural workers, immigrants and refugees, Native populations, and yes, you all mentioned people living in poverty. So yeah, those are all extremely vulnerable populations to exploitation and human trafficking. So COVID-19 has exacerbated health impacts on these already vulnerable populations, including people who are at risk of or already experiencing human trafficking. So the economic impact of COVID has led to increased homelessness and youth in particular, and they are at an increased risk of various forms of exploitation, such as survival from sex and labor exploitation. And child abuse is also on the rise during COVID, which may have caused more youth to leave the home and puts them at a higher risk of human trafficking. And school closures have meant that youth are spending more time online, which also increases the risk of human trafficking. And COVID has also worsened experiences of youth already experiencing exploitation because they've had exposure to settings where social distancing and enforcement or the ability to wear masks have been limited. So then they're at higher risk of COVID, they're at higher risk of exploitation, and it's just been a very lose-lose situation for a lot of these vulnerable populations. And then there have been fewer opportunities for them to connect with supportive services due to that increased isolation and overburdened healthcare systems. So with intimate partner violence, we often think of sex trafficking as being more closely related, but labor trafficking intersects with intimate partner violence as well. So this study was conducted in the Midwest to better understand this overlap, and it found that many foreign-born victims were coerced to remain in their situation due to their perpetrators exploiting the victim's immigration status. And the primary tether that kept the victim in a situation of exploitation was the lack of other options to provide for themselves and their families. So here are some of the stories from survivors from that study, which show that intersection of intimate partner violence and labor trafficking. So one survivor said that she had access to some of her wages, but the majority was held by her boyfriend, so she depended on him for food and shelter. Another person said her husband had been prostituting her for several years, as well as abusing her. Another client felt stuck in domestic servitude situation because the uncle would threaten her family if she didn't do as he said. The abuser would threaten to call ICE or the police if she complained about the way he was treating her. Someone said that their abuser harms other victims, and the uncle had physically abused the client's mother and brother. And someone had a boss that would say that the client owed him $900 in addition to monthly rent charges. And they would say, oh, you can work off your debt in 3 years, to try to keep them in that situation for an extended period of time. So here's the power and control wheel. And this might be a helpful tool to use with your clients so that they can better understand the overlaps between labor and sex trafficking and intimate partner violence. So this is very similar to the other wheel that we mentioned earlier with those dynamics of power and control, but it just kind of shows the overlap. So coercion and threats, intimidation, emotional abuse, isolation, those are all big components in each of these different situations. So then here are some recommendations for domestic violence advocacy programs and how you can engage with survivors in talking about labor and sex exploitation and trafficking. So just work on providing opportunities for in conversations you're already having, for survivors to open up about the labor and sex exploitation and trafficking. Share with them how that power and control shows up in intimate relationships and in their work setting. You can share their worker rights and legal protections and offer resources and referrals, and recognize that some of them may be afraid to follow up with those services. And safer planning includes the exploration of economic abuse, debt bondage, and sexual coercion, whether that be at work or within their intimate relationships. So before we move on, this is just kind of a fun video with a little bit like a mindfulness practice. So this is a very, very shift in gears, but it's very compelling. So we'll play it and then I'll talk a little bit more about it. Let's see. Are you able to hear it?
No.
Hey, Abby,
Sorry, were you able to hear the sound?
Sorry, Abby, this is Lindsay. You might have, when you do your share screen, I think you have an option to share sound from your device.
Or share with audio, I think.
Okay,
Yeah.
found it. Okay, thank you. Let's try.
The Critter Creek Farm is basically, it's our property, it's our home, and we raise goats. We raise fainting goats and Nigerian dwarf goats. I'm also a full-time flower farmer. Goat yoga started about 3 years ago when my kids left for college and no one was coming to the farm, no one was playing with the babies except for me. And I really promise that when you buy baby goats from us that they're very socialized, they're friendly. So goat yoga is a way for us to bring the babies off the farm, to have them get used to the public, get used to people, get very socialized, and they absolutely love it. They are born naturally afraid of people, so this really trains them to become social. And they are herd animals, so the more they're with people, the more they think people are part of their herd. A lot of our folks have never done yoga before. It's very intimidating going to a yoga studio, especially if you've never experienced yoga. So a lot of people, this is their sort of gateway, I joke, because you know nobody's looking at you. You know, they're playing with the goats, they're having fun. We have people each session that never do like a yoga. They just sit on the mat, hold a goat. So there's no pressure if you just kind of want to try or see what yoga's about. There's no pressure.
You're not concerned with, doing your best postures. You're less concerned about doing your best yoga. It's more about the goats having fun, having a good time, laughing.
I was an ER nurse for 25 years. And a lot of pressure, a lot of sadness, a lot of positive stuff as well, being an ER nurse. But when I started the yoga 3 years ago, it was so nice just to be guaranteed a fun, happy, positive experience every week. Every week, watching people love on the goats. It was just so therapeutic for me to watch that.
Yeah, so we like to share that video because something very compelling about it is that she is an ER nurse. So she's a caretaker and a caregiver, and similarly to working with domestic violence survivors, it can be very, very stressful. So earlier, Anna talked a bit about how you can use mindfulness to keep you grounded. And this ER nurse decided to blend her interests, which were goats and yoga, which seemed to have nothing to do with each other, and made them blend together, and it made her and this practice very accessible to other people in the community. So we're going to throw it back to Anna for the next module. Let's see. Oh, yeah.
Okay, so as we move on, we are going to move into module 4. We may even get done a few minutes early, which is about the health impacts of intimate partner violence, human trafficking, and exploitation. And so we're just going to review some of the health consequences of those. So how do domestic violence and trafficking or exploitation impact health? If anyone has any thoughts on how you think domestic violence or human trafficking impact health, would you please drop those in the chat? And it can be about behavioral health or reproductive health. Marcia said, many won't seek care due to fear of being reported to legal services. Yes. And that community health centers can help clients that are undocumented. Nina said, physical harm, sexually transmitted diseases, mental health. Yes. Mental health affects a patient's physical health and vice versa. Yes. Thank you for those who shared. So it's more than just a physical injury. There are many long-lasting health consequences for intimate partner violence and human trafficking. In addition to the immediate bruises and physical injuries, these health consequences can persist even after an abusive relationship or trafficking situation has ended. So while these specific health consequences are what the research shows, there really could be a number of health conditions associated with intimate partner violence and human trafficking, including behavioral health and mental health issues, relationship difficulties, and how people present and interact in their lives because of the abuse or trauma that they experienced. And so this slide just kind of details a few of those. And so as we move on, we're going to talk a little bit about brain injury caused by domestic violence. So partner-inflicted brain injury is something that is kind of new, I think, that we're starting to talk about in the DV field. And so partner-inflicted brain injury is when a person's brain is hurt by strangulation and or blows to the head that can cause a traumatic brain injury, concussion, or other type of brain injury while experiencing domestic violence. So the most common persistent symptoms of a traumatic brain injury are headaches, fatigue, memory loss, depression, and communication difficulty. And traumatic brain injury is often missed, and it's recommended that assessment for traumatic brain injury be done with the HELPS brain injury screening tool, which can also be used to address strangulation. And the tool can be in the slides that we will send you. Strangulation is actually one of the most common forms of a traumatic brain injury that survivors experience. And then other common forms that survivors can experience are blunt force blows to the head that can cause concussions, that can be a result of being slammed into the wall or being shaken so hard that the brain hits the wall of the skull. Non-fatal strangulation is an important risk factor for the homicide of women, so underscoring the need to screen for non-fatal strangulation when assessing abused women in emergency situations is very important. So just to reiterate, what causes a brain injury is blows to the head. So either from someone using their hands to hit a person in the head or hit their head against something, or their feet hitting a person with an object, or someone falling or being pushed and having their head hurt, severe shaking, and then strangulation and violence that would cause one to struggle to breathe. And then these are often unidentified, untreated, and repeated. So a lot of times survivors are not aware that they may have a possible brain injury, and so they will continue to be abused and continue to have these injuries repeated without seeking proper medical attention. And so we are going to watch just a short video from Rachel Ramirez, who runs the brain injury research at ODVN. And I just want to know, Abby, how did you share your sound?
Okay, go up to, I think it was under, oh, I can't see it anymore because I'm not sharing. It was like the top right of the
talk about
options, and then you go down to share sound. I think it was under like share options, I believe.
Thank you.
in someone's eyes, like he looked through me like I wasn't even there. And I remember him putting his hands around my throat and like thinking like, I'm going to die.
When we think about the first picture of a domestic violence victim, the kind of classic iconic image of a battered woman as a woman with a black eye, right? Which one of the things that I realized now in the context of this work is she very well could have had a concussion in the context of that black eye, but it is something that none of us in the field have thought about.
And I don't remember much after that, but a nosy neighbor saved my life. Like somebody had heard all the stuff going on and knocked on the door, and that was the only reason I'm still alive.
And how we hadn't, it's one of those things you say it We look at the data, we talk about brain injury and hits to the head, and it becomes very obvious very quickly. But even in my role at my organization as a statewide leader, having led a trauma-informed initiative across the state, trained in other states about the work that I was doing, never once had I mentioned brain injury. And how did we manage to miss that?
81% had reported being hit in the head. 50% or so many times that they couldn't remember. And 83% of the survivors working with the organizations reported that they had been choked or strangled so that their brains had been deprived of oxygen. And the sad part for me is I'm an EMS educator. Like I teach trauma. That's like one of the things I love. And yet, even though as much as I know about trauma, I totally missed the strangulation part, the brain, and the effects that it's had on my body. Many survivors who have been living with unmet need regarding brain injury intervention for a long time do end up developing comorbid issues like mental health issues and substance use issues, struggles with suicide. So unless we're identifying the underlying brain injury early, there can be other long-term health impacts for survivors of domestic violence who are not receiving the services that they need. At one point, I attempted suicide. And so it was like, if they would have found this earlier, like, you know, my family has watched, and my friends and family have watched me, you know, try to end my own life and stuff. And it's like, that all could have been avoided had the right people had the right knowledge.
This has just kind of changed how we think about things and how we want to do things. And we're very, very hungry for helping us tackle this, because this really hasn't been tackled in this way before, and helping us from a practice level figure out what this needs to look like in the very complicated, very challenging work that domestic violence agencies do.
So that was just kind of an overview of some of the work that ODVN is doing. And in that video, you could see the tools that ODVN has produced to provide to agencies that you can use when working with a client to help identify if they possibly have signs or symptoms of a brain injury. And then these can also be given to them that they can then take into their doctor and say, okay, these are the symptoms I'm having, along with different tools to help track. And so all of these are available on ODVN's website if you go to odvn.org and then go to the brain injury research section. And so you can access any of those there if you would like. And so just to kind of reiterate what brain injury can look like, it can affect one's thinking, one's emotion, behaviors, or physical problems. So if you're working with a client and they're saying that they're having difficulty remembering, or they're feeling like their brain's in a fog, difficulty concentrating, signs of depression or irritability in their moods, physical problems such as headaches or lack of energy, blurred vision, or same impulsive behaviors, problems controlling emotions. Any of these could be a symptom or sign of brain injury. And so just knowing that that could be something that a client's struggling with, and maybe they don't even recognize what's happened, or they could not remember that their head was hit during an incident. So a little bit more about understanding strangulation and traumatic brain injuries. They're extremely common forms of physical violence, one that's particularly controlling in abusive relationships, and it's often repeated. It's so normalized because it's so common and because there aren't always immediate repercussions. And so strangulation is also a strong indicator for DV homicide or serious reassault. Strangulations and TBIs are not always painful. They don't always leave marks or make one's voice raspy or have blood vessels in the eyes. So it may not be thought of as serious, but it can still cause the oxygen to not get to the brain. So it's important to know that victims can die from a traumatic brain injury hours or days after the assault, and it only takes 4 pounds of pressure for about 10 seconds to make someone unconscious and potentially leave permanent brain damage. So that's just something else to consider when assessing lethality for a survivor. So like I said, those materials can be accessed on ODVN's website under the tab Center on Partner Inflicted Brain Injury. And then if you're wanting more information or have any questions, you're welcome to email Rachel at this email. And again, this will all be in the slides that are sent out. So as we transition on, we're going to move into talking about women, opioids, and violence. So we want to talk about the connection between trafficking and substance abuse. There is an increased use of heroin among trafficking survivors. And in addition, thinking about substance abuse more generally, it's important to highlight the role of opioids in or as a result of intimate partner violence and trafficking. Opioid use disorders are associated with intimate partner violence, victimization, particularly among women, and women may be particularly susceptible to such violence when under the influence of opioids. So these points just underscore how important it is for providers to ask our patients or clients if anyone's interfering with their treatment for mental health or substance abuse, and also to consider what a patient or client who is using substance abuse may be experiencing, such as coercion. So substance abuse is another way that abusive partners can exert power and control. And so these statistics were the result of a phone survey from 3,380 people through the National Domestic Violence Hotline and National Center for Domestic Violence, Trauma, and Mental Health. So we just want to note that the role of substance use in abusive relationships can take many different forms, as we can see with the statistics on the slide. So asking directly a client or a patient if their partner is forcing them to use drugs, messing with their treatment plan, or preventing them from seeking help or treatment can be an important step to intervention. And so we just want to make sure that people are reading and seeing that 27% of hotline callers reported they were pressured or forced to use alcohol or other drugs. And then 24.4% were afraid to call the police. 60.1% tried to prevent or discourage them from getting help. And then 37.5% of abusers threatened to report alcohol or other drug use to someone in authority to keep them from getting the help that they wanted. So, you know, there are many reasons that folks aren't able to seek treatment. So in thinking about substance abuse in shelters, this is a good example here of why it's important that community health centers and advocacy programs can partner. Sometimes shelters have policies where you can't be in a shelter if you're using substances or if you're not in a treatment program. And many of the community health centers actually offer lots of different kinds of treatments. So research suggests that women may also be more likely than men to use prescription opiates to further self-medicate for problems such as anxiety or stress. And then we know that if you're able to partner with your community health center, they may be able to offer these treatments such as Suboxone or transportation and translation services or other specialized treatment options. And so this is kind of at the heart of what our partnerships can do, or potentially do if we are able to make them. By partnering, we can meet patients where they're at. And so this was actually a study that looked at intimate partner violence survivors and the overlay of issues that they may be struggling with. As with physical health, experiencing intimate partner violence or trafficking can have a significant negative impact on the mental health and substance use coercion. So in this study, 57.4% met the criteria for PTSD, 56.4% met the criteria for depression, and then 18.1% met the criteria for alcohol dependence, and 6.4% for substance dependence. So this is just another example of why it's so important for us to partner with survivors and help them, heal and support them through this difficultness of separating from their abuser, getting help, while also struggling with these other issues. And so this is just another example of a collaboration that was done in Orange County, California in 2017 to look at the overlap of substance abuse, mental health needs, and intimate partner violence. So this is what was learned about the barriers, and again, why it's so important for advocates to support meaningful connections in community health centers. And so this just describes the amount of people that could not afford services, or the percent of people that couldn't afford services or didn't seek services because of a waiting list or couldn't get away from a partner. And then the same for substance abuse services. So it's kind of shocking that 25% there was a waiting list for it. And then as we move on, we just want to share that we have a tool to help you support the health needs of clients. It has a sample intake questionnaire and then guidance, and it also suggests which questions are more urgent and need to be asked right away. There are also questions that, if asked, or for their children are currently taking any medication that they had to leave behind, or if maybe they need a COVID test or need help getting the COVID vaccine. So this is just a tool to help facilitate this in your center. And you can, I don't know if it's actually there, but we can either drop it in the chat, or again, you'll be able to get it from the slides when they're sent out. And so, as I mentioned, some health conversations are more urgent and require a faster time frame. For example, if we're looking at emergency contraceptive, there's a 5-day efficacy window, and the sooner it's administered, the more effective it is. It also, the fatality risk stemming from strangulation in the hours and days after an assault. So if the client hasn't been seen by a primary care provider in some years, there may be other chronic health issues that are undiagnosed. And so an advocate may work to support clients with other health issues in a more flexible timeline, so they don't have to address everything at once. So this could be health insurance enrollment, substance abuse support, or other health and nutrition and sleep and wellness support. So really, we just need to be talking to our survivors about why we're asking about their health and telling them what the information will be used for, so that they're aware. And then there are also other questions about health and opportunities for them to get care that aren't urgent. So we recommend talking with clients about these things after they're settled into our setting. And so this could include, this guide also includes recommendations about system change pieces too, as well as a QA/QI advocacy assessment tool that is part of our evaluation. And so this is a case example of an innovative concept that extends the partnerships of health being a centered partner of healing for survivors in shelter. Rose Brooks is a DV shelter in Kansas City. And so they partnered with the local med school and had nurses rotate through the shelter to provide services. So the providers were learning about human trafficking and domestic violence, but then they were also able to provide immunizations, STI and pregnancy testing, and asthma management to the folks that were in the center. And so additionally, we want to talk about the possibility of health services delivered to DV programs. So what is possible when we're able to partner with our community health center? We know that lots of community health centers do have mobile units, so they could drive and potentially offer services, or they could offer mobile pharmacies as well. So in the example of Brooks, they had a relationship with their local pharmacy, and so they would deliver to the agency. So if they needed a prescription for an asthma inhaler, they could give it delivered to the shelter in a seamless process, since they did have that connection. And so we also have opportunities here to help provide child vaccinations, healthcare enrollment, reproductive health, and mental health services. In addition, community health centers have parenting and prenatal programs. So we know many advocacy programs remain unaware of home visitation programs and other opportunities that happen when they're developed and implemented. So the overlap of services described on the slide doesn't cover the opportunities for all partnerships, but it does provide some ideas of potential opportunities that clients could access from their community health center. And then in addition, given what we know about the barriers and historical inequalities and racial disparities, we think it's important for advocates to know what helps pregnant people and identify additional community partners to support pregnant and nursing people, such as doulas and midwives. So doulas are, or doula-assisted mothers are 4 times less likely to have a low birth weight baby and 2 times less likely to experience a birth complication involving themselves or their baby, and significantly more likely to initiate breastfeeding. And we know that breastfeeding is good for the bonding and health of the baby, and the stress of intimate partner violence can impact the health production for mothers. So that's when these lactation specialists and doulas can come in and help provide support to clients. Does anyone have any questions about that before we move on to our last section? I will pass it back to Abby to go over supporting reproductive health.
Sorry, I was talking and I was still muted. So we are going to move a little bit into a conversation about reproductive coercion. So first, I want to start by having people drop in the chat what are some ways that they believe that an intimate partner can interfere with a survivor's birth control or reproductive health. I can't see my chat box right now, so I'm not sure if anyone has sent anything. But like Anna mentioned, one way is that the intimate partner violence will interfere with milk production, so it interferes with breastfeeding. Oh, I found my chat box. Okay. So we got refusing to wear a condom or taking it off mid-intercourse. They might not allow them to seek medical services, hide birth control, forced pregnancy, forced abortion, forcing someone to use long-term birth control like an IUD. Again, refusing to use condoms or hiding birth control, sabotaging, using guilt and manipulation, STDs. Yeah, those are all very real ways that abusers interfere with a survivor's birth control and reproductive health. So we are going to then start with this little video that will talk about that connection between intimate partner violence and reproductive coercion. Let's see.
Making the Connection, an integrated response to intimate partner violence and reproductive coercion, is an innovative educational series created by Futures Without Violence. While the term reproductive coercion is relatively new to the field, the connection between violence and poor
Sorry, my computer's trying to load and there we go.
Making the Connection, an integrated response to intimate partner violence and reproductive coercion, is an innovative educational series created by Futures Without Violence. While the term reproductive coercion is relatively new to the field, the connection between violence and poor reproductive health outcomes has been well documented across disciplines for the past 25 years. Reproductive coercion involves behaviors that a partner uses to maintain power and control in a relationship related to reproductive health. Dynamics include birth control sabotage, pregnancy pressure, and pregnancy coercion. Birth control sabotage is active interference with a contraceptive method by someone involved in an intimate or dating relationship with an adult or adolescent. Dynamics include hiding or destroying birth control pills, intentionally breaking condoms, and removing contraceptive rings or patches against her will. Pregnancy pressure involves behaviors that are intended to pressure a partner to become pregnant when she does not want to be pregnant. These behaviors may be verbal or physical threats, or a combination of both. Examples of pregnancy pressure include, "I'll hurt you if you don't become pregnant," and "I'll leave you if you don't become pregnant." And pregnancy coercion, which involves threats or acts of violence if a woman does not comply with the perpetrator's wishes regarding the decision of whether to continue or terminate the pregnancy. Multiple representative studies demonstrate that at least 1 in 4 women has experienced sexual or physical violence at the hands of her partner. In family planning settings, prevalence rates are even greater. In fact, the incidence of physical and sexual violence can double. As many as a quarter of women coming to family planning clinics report that they have experienced reproductive coercion. By defining reproductive coercion, we have a lens to understand this very specific and common form of abuse. This knowledge transforms the role of healthcare providers and the way in which they can help women prevent unwanted pregnancies and STIs and promote their safety. Recent evidence has shown that a brief intervention for reproductive coercion reduces the likelihood of pregnancy coercion by 71%. Women who received the intervention were 60% more likely to end a relationship because it was unhealthy or unsafe. In this series of modules, we will show examples of ways providers can address reproductive coercion, providing language, tools, and techniques for effective intervention, changing the standard of care, and in doing so, changing women's lives. Making the Connection, an integrated response to intimate partner violence and
Okay. So reproductive and sexual coercion is defined as behaviors to maintain power and control in a relationship related to reproductive health by someone who is, was, or wishes to be involved in an intimate or dating relationship with an adult or adolescent. So first, what do you all think is missing from that definition? So some of the dynamics that are related to intimate partner violence and human trafficking and labor exploitation and sexual exploitation are kind of missing from that definition. So, for example, the ability to have children when they want to isn't really explained in that definition. Like that experience of a forced abortion or making someone take an emergency contraception routinely as birth control. So those are ways that they're maintaining power and control, but it's a very broad definition, and they kind of focus on just controlling, not just, but that can include explicit attempts to impregnate a partner against their wishes or controlling the outcomes of a pregnancy, and coercion is a big part of this definition. So this quote is from one of the callers to the National Domestic Violence Hotline in response to the survey on reproductive coercion that they referenced in the video. So the quote is, "He knows I don't want to have another child. I've told him before. He says it will be okay. We will get a house soon. Thank God I got my period yesterday, but he was furious. If you hadn't asked me those questions, I wouldn't have thought of it like that. I wouldn't have thought that he was a manipulative person. I really wouldn't." And maybe you've witnessed a situation like this in your work where a survivor is being coerced into having more children than they want to. So we're going to talk a little bit about how you can address that. So first, just take a minute to reflect on your comfort level right now with talking to clients about reproductive health. So think about whether or not you feel comfortable asking them questions, offering basic information about reproductive health needs, and making referrals. So the blue would represent very comfortable, and the red would be not comfortable at all, and the green is somewhere in the middle. So, and you don't have to share, just kind of take a minute and think about where you are. So we'll come back to this and see if your comfort level changes at all by the end of this training. So this section is designed to address the barriers that were identified by advocates in the field. So some of these barriers are the same barriers that were identified by health providers when it comes to their comfort talking about intimate partner violence or human trafficking with their patients. So these barriers include it's outside the scope of their work and they don't know, or they don't understand how it's related. They're not comfortable with initiating conversations. They don't know what to do with these disclosures. They have a lack of time, or they have concerns about emergency contraception and moral and personal beliefs. So we're going to explore that last barrier first, the concerns about emergency contraception or the morning after pill or Plan B, that contraceptions of that nature. So another short video about Plan B, just to get an understanding of it before we dive deeper.
Let's talk Cash App. Want to custom design your own masterpiece of a debit card?
Contraception. With a variety of methods available, many people are able to avoid unintended pregnancies. But what happens when things don't go quite as planned? Thanks to modern science, a second chance is possible. So how does emergency contraception or Plan B work? And what exactly is happening inside the female body? During the female menstrual cycle, many hormones are released, beginning a chain reaction. The pituitary gland in the brain releases FSH, which stimulates the growth of follicles and a premature egg in the ovaries. These follicles then release estrogen, which helps prepare the uterus lining and triggers the brain to release luteinizing hormone, or LH. LH then triggers ovulation, in which the egg is released into the fallopian tubes, where it will spend around 12 to 24 hours waiting to be fertilized. If the egg isn't fertilized in this time, it begins to dissolve and is shed away with the uterine lining during menstruation. Though this window of opportunity is brief, it's increased by the fact that sperm can live for up to 5 days, so the keen sperm from days ago show up early to the show, anxiously awaiting ovulation. Birth control pills taken on a regular basis modify these hormone levels. By increasing progestin levels, the body thinks it's already released an egg or already pregnant. It effectively decreases FSH and LH and the cycle halts. But in the case of emergency contraception, which is only taken if regular contraception methods fail, a few different mechanisms take place. The most important thing to understand is that fertilization doesn't happen immediately or even within hours after intercourse. Instead, the sperm must undergo a few biological changes in the fallopian tube first, which takes time. This is why emergency contraception is still possible the morning after, and can actually work up to 5 days after intercourse. If taken during the first half of the menstrual cycle, emergency contraception works specifically to prevent ovulation. This way, the egg is not released even though it may be ready and the available sperm cannot fertilize it. In cases where it's too late to inhibit ovulation, emergency contraception is thought to also thicken cervical mucus, trapping sperm. As well, it may directly inhibit fertilization between sperm and egg. Clinical studies show that emergency contraception prevents pregnancy before fertilization. No studies have shown an effect from emergency contraception if fertilization has already occurred. It does not stop implantation from happening, nor does it have any effect after implantation has occurred. In this way, it's unable to cause an abortion. And while there are some minor side effects to these drugs, such as nausea and headaches, scientific studies have demonstrated its safety in women of all ages and found that the benefits far outweigh any risks. Got a burning question you want answered? Ask it in the comments or on Facebook and Twitter, and subscribe for more weekly science videos.
Okay. So we are going to talk a little bit more about some of the myths that exist around Plan B. So you heard in the video that you heard a little bit about how this actually works. So you can see that this medication does not cause miscarriage or abortion. It will not hurt a pregnancy if you are already pregnant, and it can be taken up to 5 days after unprotected sex. The sooner the better for efficacy, but it is legal, safe, and it's available over the counter at Walmart and like CVS, Walgreens, different kind of convenience stores for about $50 to $70. But it's available at low or no cost at many health centers, which is another reason why having a health center partnership is so critical, because this can help with those kind of forced pregnancies and that reproductive coercion. So Plan B is very helpful for women who are not overweight, but for your overweight clients, there is a much better medication called Ella, which it's not over the counter. So you need a prescription from a community health center, which is why this partnership can really make a difference. So up to 5 days after unprotected sex, you can also have an IUD inserted as a form of emergency contraception. And copper IUDs are very long lasting and can prevent future, like they can act as a morning after pill, but they can also reduce that risk of unintended or forced pregnancy in the future. So all women should be advised to start longer term contraception immediately after they take an emergency contraception. So this copper IUD is a great segue to suggest to your clients. So the copper IUD is an important harm reduction strategy because a person's period or bleeding pattern also isn't altered with this method, as it can be with other birth control methods. So it's possible to cut the strings in the cervical canal so that they can't be felt or pulled out by a partner. And because this can be such a helpful harm reduction strategy for survivors, it's important that this information be included in our patient education. So the copper IUD prevents pregnancy by blocking sperm from reaching the egg, and it can also be inserted as that emergency contraception to prevent pregnancy up to 5 days after unprotected sex. So we have another video that we are going to show you to show the discomfort that a lot of advocates have with emergency contraception and talking about reproductive coercion with their clients at a shelter intake. So we'll talk a little bit more about safety planning concepts after this, but for now, just kind of watch the way this advocate interacts in this conversation. And this video also came from Futures as part of that partnership with domestic violence advocates working with reproductive health providers. So it has some real life comments and experiences that were encountered as part of this partnership so that we can start addressing some of those issues.
Hey, Ruth. It's good to see you taking a break. It's been a crazy busy day. How are you settling in?
Good, good.
I think things are done a little differently in Westport's shelter, so how are you feeling here at Safe Haven?
It's different, that's for sure. And I'm struggling with it a bit.
Well, what's feeling like a struggle for you?
I just don't get why we're talking about emergency contraception and pregnancy at intake. I keep feeling that it's an unneeded burden.
Right. I get it. And I forgot, you weren't here when we did training on this. That totally makes sense. There were some staff here that were really, really uncomfortable about this work when we started. It was kind of a mutiny about it, actually. Folks just flat out wouldn't have these conversations with the women.
So what happened?
Basically, we learned that there was a lot of missing information, and we'd assumed that staff understood more than turned out to be the case. So we backed up the train. See, in 2010, there was follow-up to an important study that was done with women in family planning clinics in Northern California. The National DV Hotline surveyed over 3,500 women about reproductive coercion. They asked the women in the survey if she had a partner who was trying to get her pregnant when she didn't want to be, to try to control her, which can involve a range of things from destroying birth control or preventing access to a clinic or threatening to hurt her if she used it. And the bottom line is, similar to the study, 1/4 of the women said yes, that had happened to them.
I mean, I do know that happens because women have shared that with me. Some who came into the shelter very pregnant, they told me things like that happened.
Exactly. But what that means for our work is that safety planning is bigger and different than what we ever realized. Like planning around reproductive safety if she returns to the relationship, or knowing about hidden forms of birth control. And for a lot of folks here, it pushed big buttons to talk about having emergency contraception available at shelter.
I can imagine. We weren't allowed to even give out Advil or regular cough syrup at our shelter.
It's funny you mention that. The Washington State Coalition did this really cool info sheet for advocates about new thinking that's been going on in the field. See, it helps staff to see that access to over-the-counter medication is part of respecting her judgment and healing from trauma. We stop being the deciders about what she wants or needs.
I get that. I always thought that rule made women's lives so much harder than they needed to be. But I know personally that talking to her about sex and birth control and all that stuff can be really upsetting. And do we really need to be doing this the first 24 hours after she gets here?
I totally hear what you're saying, and it is really important. And if access and timing were an essential part of this, we would wait. And you're getting to the heart of what we realized staff didn't understand, that we can, if she wants help with it, help her prevent a pregnancy by getting her emergency contraception. It can be given up to 5 days post unprotected sex, but it's much more effective the sooner you take it after sex. Well, we can imagine the huge impact on a woman's life to have a pregnancy that wasn't planned.
I heard emergency contraception can really screw up someone if they take too much, or especially if they might be pregnant. It can cause a miscarriage or even hurt her.
Well, that's a big part of what the training is about. At first, it felt like we were doing an episode of Mythbusters, and basically, EC in no way affects an established pregnancy, nor causes a miscarriage. It's kind of like if you have a friend who missed some pills, got pregnant, kept taking pills, but didn't realize she was pregnant till maybe a month or so later. Taking the pills didn't hurt or interrupt the pregnancy, and they weren't bad for the pregnancy. EC works in the same way.
Well, that makes sense about why emergency contraception is over the counter, I guess.
Exactly. So I'm getting ready to do an intake with a woman, Lori, who just came into shelter last night. Her kids are getting settled in the playroom. Would you like to sit in on the conversation?
Yeah.
So we have a couple minutes to debrief that video, so feel free to put some general comments or reactions in the chat box, in addition to answering some of these discussion questions on the screen. Because first have, okay, so it is interesting. Oh, sorry, that was from the definition. But yeah, can you see yourself or your colleagues being resistant to the idea of doing assessments on reproductive coercion? Yes, I know that at the shelter that I worked at, we didn't have emergency contraception in the shelter until after they had actually received this training, because we had assumed, well, it is expensive, so a lot of our clients aren't able to afford it. So it's a great thing for us to have there available to them. But it's also great to have that partnership with health centers so that they can go somewhere to get them at low or no cost. But we wouldn't know that they needed it unless we did these assessments and learned that it was a need for them and had them share that information with us. Anyone? You can also respond. Ohio has a specific gag order on offering emergency contraception options. So I know it's a tricky conversations for advocates to have sometimes. Yeah. Yeah, absolutely. And it's difficult too when there is those different moral and personal beliefs around particularly abortion, but some people have those opinions about emergency contraception and birth control as well. Or what about, do you think that the advocate did a good job articulating the relevance of that need for offering emergency contraceptions to their clients as well? Or what else could she have added? Let's see if we have. I work at a rape crisis center, and we have a lot of restrictions around talking about abortion and emergency contraception. I formerly worked at an abortion clinic, so I would love to talk about this with my clients. Prohibits assistance for abortions. Wow. That definitely puts up a barrier too in talking about options for your clients. Wow. That's interesting. I didn't know that that was prohibited. Huh. Let's see, so do you from the rape crisis centers, do you know if that also prohibits talking about like emergency contraception, or is it specifically for abortions? also emergency contraceptive. Wow. Okay. Yeah, hopefully they don't have that limitation on talking about emergency contraception as well, because it's not the same, but it is kind of an alternative and a way to open that door for where within the bounds of what you're allowed to discuss. So yeah, hopefully I'll have to get some information on that as well. I did not know that, but thank you for sharing. So we know from research that clients are usually really welcoming in the opportunity of being asked about their reproductive health. And this is important to keep in mind, as some advocates may be concerned that their clients will think this is intrusive or embarrassing or overwhelming. But the Futures experience with small pilot studies showed that women welcomed that opportunity to discuss their experiences with unwanted and unprotected sex at intake. This is part 2 of that video we just watched, and will show that conversation that they are having at intake. So you can see how she speaks with a survivor about what she may need related to her reproductive health.
So, Lori, maybe you remember me from last night. I'm Lee, and this is Ruth. And if it's okay with you, I'd like Ruth to stay and listen and learn while we finish your intake. Would it be all right if she stays? Or if it's not, that's fine. Just let us know.
No, it's okay. That's fine.
So, how are you doing? I heard your kids are having a great time making art in the playroom.
They didn't want me to go at first, but then they got comfortable. I told them I would keep checking on them.
Well, that makes a lot of sense. And if you feel like you need to jump up and check, that is totally not a problem. We can come back to this later, too. We're just trying to help in whatever way you all need support.
Thanks.
Okay. So, I know we started some paperwork with you last night, and we have just a little more to go over with you today. Basically, we talk to everyone who comes in about this. We give them this little card that talks about some of the other ways that a partner might try to control or hurt you in a relationship. Sometimes it's about your reproductive health. Many women who come to our program have experienced situations putting them at risk for unplanned pregnancies. And we want you to know there is a safe medication that you can take called emergency contraception. And some call it EC, or the morning after pill. Take it up to 5 days after unprotected sex to prevent pregnancy, if that's something that would be useful for you. Now, emergency contraception is available if you had unprotected sex without condoms or any form of birth control in the past 5 days, you had a condom break, get pulled off, or fallen off in the last 5 days, you've forgotten to take your birth control pills or change your NuvaRing or contraceptive patch in the last 5 days, or you're worried that your partner was trying to get you pregnant when you didn't want to be, messing with or damaging your birth control, like not pulling out when he said he would, or poking holes in your diaphragm. Now, are any of these things a concern for you today, or something you want more information about? Is EC or a pregnancy test something that would be useful for you today?
Actually, I was kind of freaking out about having left my pills at home by mistake. I really don't want to get pregnant right now.
Right. It totally makes sense that stuff you really need sometimes gets left behind. Actually, we have a public health nurse, Liz, that we work with, and she could easily bring pills over to the shelter today, so you don't have to go home to get them. And she can talk with you more about EC. Liz or any of our advocates can also talk with you about some of the things on the card in more depth. Methods of birth control out there that in the future your partner doesn't have to know about and you can control.
Thanks. Thanks for asking. If it's okay, can I go check on the kids now?
No problem. So, what did you think about what you saw?
I think she looked relieved to have information and to get her pills. And I see how you kind of kept to the facts. I like that.
Okay, so circle back around if you have other questions on this or other stuff comes up. But your experience is one that really many staff have had to work through, but once they did, they realized that starting a conversation about emergency contraception was really helpful for the woman that we were working with, not something that was a burden.
Thanks.
So after watching part 2 of that video, think about some of these questions as well and read and leave those responses in the chat, or feel free to unmute yourself. So what did you think the advocate did well, or what would you change about that interaction? Or can you see yourself or your colleagues integrating this kind of assessment for reproductive coercion, and offering on-site emergency contraception in areas where you're able to? Said did well. The neutral tone gave a wide range of options and scenarios. And Caitlin would change. I would shift some of the language to be more focused on reproductive coercion rather than if you had unprotected sex or forgot to take your pills. Yeah, that's a good point. It takes some of that blame off of the victim and shifts it to they were coerced. Great to give her options and let her be in control of her choices. Yes, I definitely agree. Yeah. And if you have any other questions, also feel free to leave those in the chat. So we are in the final stretch, but we'll go ahead and take a quick 5-minute break. Just kind of know that's some heavy information, so we can take 5 minutes and come back at do a 3:57, I guess, and wrap up with the rest of this training. And so, like I said, if you have any other questions, feel free to go ahead and leave them in the chat, but I'll see you back in 5 minutes. right, so we are moving into the last section of this training, and we're going to spend a few minutes looking into the reproductive health intervention that came from Futures. So I put the link in the chat in case you want to look at it a little bit closer up, but it's also this card that, this card that you can see on the screen. You can incorporate this card into your intakes, support groups, or as part of counseling or case management or during prevention education sections. But it kind of goes through different types of abuse that a survivor may experiment. And one of those questions is, does my partner mess with my birth control or try to get me pregnant when I don't want to be? So it's modeled after some domestic violence safety cards, and it asks those key questions, and it can be used as a prompt for you to open that conversation with your clients. So one idea is that you could give that card to everyone, say you work in a shelter during an intake, and then you can use the sample script, which reads, we give 2 of these cards to all the women in our program because we want you to know about birth control methods your partner doesn't need to know about. We want you to have this information because relationships can change, and so you have this information to help a friend or family member in case it is an issue for them. So you have 2 cards, one for the person you're working with and one for them to give to a friend or family member. And you can always edit this script so it fits better your style and where the setting where you work. But research from that future study showed that clients felt empowered by being able to help someone else in their lives or being able to help themselves when they have that information. So Futures has many different safety card tools to address different populations and languages spoken. So there are different options, and you can pick whichever one best suits the population you're working with. So they offer an array of different languages for different literacy levels, patient education safety cards, cards that provide the information on healthy and unhealthy relationships, the impact of those relationships on health, and they list different national referrals for support. And the evidence-based safety card tool was developed to help clinicians and domestic violence or sexual assault advocates open those conversations about domestic violence and sexual assault and what healthy relationships are with their clients. And there are these little 4 or 5 panel tools that can be folded to be about 2.5 by 3 inches, like a business card, so that they are easy to take with them and pass along to another individual as well. And I know that you can also find those cards on the Futures Without Violence website for these other options. And then we're going to switch gears a little bit from talking about that in-person advocacy to remote advocacy, which of course has been necessary throughout the pandemic. So here is a sample script that can be used when you're providing remote support, since you can't share those safety cards like you could in person. So relationships are stressed and we all need support now more than ever. Are you worried about becoming pregnant when you don't want to be? Or did someone mess with your birth control? Did a condom break? Forget to pull out? The morning after pill works up to 5 days after unprotected sex and is available at your local Planned Parenthood or community health centers for no or low cost. Also, a copper IUD, which needs to be inserted by a health provider, prevents pregnancy for up to 12 years and can be removed whenever you want to become pregnant. The provider just needs to trim the end of the device so your partner can't feel it or find it, and you will still have your period every month. So this script is helping make sure women have access to those necessary medical services, and it's part of rebuilding and taking control of their lives again. And these resources are as you saw in that video, they're priceless. They help those women feel relieved so that they know that they do have options. Then we also have this quote from a director at one of the first domestic violence programs that was established in the US and that began addressing reproductive health with their clients. And this was part of a multi-year initiative called Project Connect, which focused on strengthening collaborations between the public health and domestic violence fields. And it says, once we became aware of reproductive coercion, it just made sense to change the questions we were asking our clients. For our women in shelter, having access to medical services in a safe way without looking over their shoulder, it's part of rebuilding and taking control back. What do these medical resources mean to these women? They are priceless. So we're revisiting this comfort meter that we looked at earlier. And again, I just want you to look at it, and you don't need to share it out loud, but just think of how comfortable you are talking to your clients about their health in particular, or their health and in particular, reproductive and sexual health issues and emergency contraception, and compare that to how you felt before you learned a little bit more about those birth control methods and emergency contraceptions. Hopefully you've become more comfortable with that, and you have some ideas of how you can address that. Then we have this quote on defining success. So, success is measured by our efforts to reduce isolation and improve outcomes for safety and health. And some stepping stones, I guess, to reach that success would be to grow those partnerships with local community health centers, having a healing-centered workspace, incorporating the new health intake tool and systems change, promoting health insurance enrollment, reproductive health support and emergency contraception, offering clients warm, supportive referrals to those community health centers, and promoting holistic approaches to healing and support. So this is the link to the online toolkit that is a go-to resource for you all to learn more and find related tools and resources related to today's training. I will also send that link in the chat, but this website was developed by Futures Without Violence, and in an earlier project, or in an earlier phase of Project Catalyst, it was informed by 20 participating community health centers and domestic violence advocacy programs. So you can learn more on addressing survivors' health needs at that website. And another big piece of guidance that we offer on this online toolkit is how DV program staff can partner with community health centers, and how this supports the opportunity for advocates to offer their clients a warm referral to a local health center, and letting their clients know a little bit about what that health center offers. And this toolkit also has new guidance on COVID support and ways to help remotely. So for a lot of survivors, going to health visits can be scary and it can be a trigger. So we also have this brochure that helps provide some tips on how to help survivors feel more comfortable. So Futures worked in a partnership with Olga Trujillo and the National Center on Domestic Violence, Trauma, and Mental Health to develop a health brochure for those who have survived childhood or adult violence/abuse. So it helps patients with trauma-informed answers to the following questions, including, why do I avoid these visits? Or why do I have a hard time remembering what my provider tells me? And what can I do to make my dental or healthcare visits less scary or hard? And so this guide also promotes a survivor's access to these health services, and it validates why it might be hard for them to go. And it names those common experiences of disassociation. And it also kind of circles back to head trauma and why do I have a hard time remembering what my provider tells me? That can open the door to talk about memory issues, or have I been hit in the head, and those kind of connections. And then it offers strategies to talk about, or about how to talk to providers about abuse, and recommends taking notes or bringing a friend with them to help remember what providers have told them. And then it also features resources that are available on domestic violence and sexual assault, including the National Hotline on Domestic Violence and the RAIN resource. And this brochure is available in English and Spanish. And it's been offered in community-based advocacy settings as well as community health settings. The National Health Resource Center on Domestic Violence is a project from the Futures Without Violence, and it supports healthcare practitioners, administrators, and systems advocates, policymakers, and others at all levels as they work to improve healthcare's response to domestic and sexual violence. So they're available for ongoing training and technical assistance for everything that we talked about today. And I'll put their information in the chat as well, but they have an email address, a website, and a phone number to provide those resources and support. There we go. So that brings us to the end, but I am going to pass it back to Anna for a couple minutes just so she can talk a little bit about your CEUs.
All right, so we are going to finish a few minutes early. So thank you all for taking the time to participate in this training. And like I said, we will email out these slides to everyone, and everyone will get emailed a certificate of participation. If you are wanting CEUs for the training, we have to have an evaluation completed. So I dropped the link for that evaluation in the chat. Anyone is welcome to complete the evaluation, but people who complete the evaluation will get their CEUs. So if you do not complete that evaluation, you will not get CEUs, but it is not required if you are not looking for CEUs. So please go ahead and complete that, and then we'll get those to you as soon as possible. And then we can hang around for like 5 or so more minutes if anyone has any questions or needs anything or has any issues with the Google Doc. So thank you all for participating and being patient with us as we flipped our screens back and forth. Okay, this was what I was scared of. Give me a second, Rachel. When you click on it, does it say that you don't have access to it, or is it just not working? Ugh. Maybe try to copy and paste it into your browser. It's working in Chrome. Rachel, if you drop your email, I can also email it to you and see if that would work. Olivia, yes, I believe that Lindsay is going to be emailing out the PowerPoint.
Yep, I think Meg mentioned earlier that she will be sending it from our OACHC team after the training today. So you might receive it tomorrow, I would guess.
Okay. Rachel, I got your email. I think Kirsten, if you want to drop your email in the chat, I'll email it to you as well. Rachel, I just emailed it. Oh, perfect. Thanks, Deborah. Okay, Rachel, if you don't get it, feel free, my email's there to send me an email. It does say it's sent though, so hopefully it'll pop up soon.
And Anna, Meg just clarified that she will send the survey as well as the PowerPoint after the training today via email to everyone who attended. So
Perfect.
hopefully you guys will receive it a couple of times and hopefully can complete it for us.
Perfect. Thank you all.
Thank you. Great content. All right, if nobody else has any other questions, I think we can go ahead and close out. Thank you all so much, and yeah, thank you.
Bye, everyone.
Bye.